Order. Welcome everyone to this morning's session of the Public Accounts Committee. Thank you everyone for joining us. Just apologies to begin with from Sir Geoffrey Clinton-Brown, who is the chair of the committee, who is not with us today. I'm Clive Betts. I'm chairing the committee as the deputy chair this morning. Just say that members around the table are members of the Public Accounts Committee, with the exception of Josh Fenton-Glynn, who was a guest in our committee from the Select Committee of Health and Social Care. So Josh, welcome. Thank you for joining us. Select Committees and Public Accounts Committee do try to work together on these important matters. Our job here is to look at how public money is spent and whether the public are getting value for that money. And that's what we're going to do today with regard to waiting times and waiting lists in the NHS. Data shows that in June of this year, around 6 million people were waiting for elective care, and we know, our experience as constituency MPs, that constituents who are waiting to get appointments and waiting to get care is a very big issue. It's a general issue, but also particular to the individuals who are waiting. So 3 years ago, the NHS England set out a recovery plan, particularly looking at programmes to do with surgery, diagnostics and outpatients to try and get those waiting times reduced. And there has been progress, I think, in getting the longest waiting times down, but probably the overall waits and waiting lists haven't reduced as much as was hoped for when the programme began. And we've seen, as we'll go through, that some of the programmes have perhaps been more successful than others. Success in getting diagnostic centres up and running and getting more tests done. Some success with new surgical hubs, but really struggling on outpatient appointments and getting the numbers of people waiting there down at all. So I suppose always with the NHS, when one plan doesn't work, we get a new plan. And in January of this year, there was £1.5 billion allocated for capital spending to try and get further progress on these matters. So today's session, we have before us senior officials from the Department of Health and Social Care and NHS England. And I'm going to ask them to introduce themselves and say who they are and what role they have as we go down the table. Perhaps we could begin with the Permanent Secretary, Samantha Jones.
Morning, my name's Samantha Jones. I'm the Permanent Secretary here at Department of Health and Social Care.
Right, okay.
My name is Matthew Stile. I am the Director General for Secondary Care and Integration in the Department of Health and Social Care.
Right, and we just go over to the NHS England now.
Morning, Jim Mackey, Chief Exec, NHS England.
Good morning, my name is Mark Cubbin. I'm the National Director for Electives, Cancer and Diagnostics.
Good morning, my name is Megan Uphandit and I'm the National Medical Director.
Right, thank you all for coming. Now, I think we've probably been advised in advance that the committee just wants to explore one or two other matters which are of particular relevance. Indeed, when the committee met before, by chance on the same day, significant changes were announced about the eventual abolition of NHS England and the amalgamation of that function into the department, but also the serious reduction, 50% reduction in the funding for integrated care boards, which they were going to have to manage. So I suppose we want to just ask a few questions about that from a financial point of view. How's it going, Sir Jim?
Good question. So we're at an interesting point with the change process. So the change process of reduction in costs for NHS England, Department of Health and Social Care and that integration, but then also with the Integrated Care Board, changes throughout the country is a huge change, and it was a very dramatic change for the service. There was, as we'd explained on Tuesday in Health Select Committee, there's an awful lot of work done very quickly, working with ICB, chief execs, chairs and other colleagues to develop the model ICB and also try to start to reduce the variation in running costs and some of the key cost drivers such as CHC and other things. So I think that was a pretty successful exercise, difficult because we have to take a pretty significant cost reduction as part of all of that. Every ICB has a plan, has submitted a plan to deliver those changes. We've just published a model region as well this week, which is another important part of the jigsaw. And we are now just working through with Treasury colleagues how we can actually enact the change by utilising the voluntary redundancy scheme, hopefully, that will then allow people to start to implement the structure and the structural changes. In terms of how's it going so far, I think there's been a really strong leadership response, I think, across the NHS to the financial reset generally, but also embracing this change. So far this year, the NHS has managed to hold to the financial plans that we agreed at the beginning of the year. Colleagues will remember we were looking down the barrel at about the 6.6 billion deficit, 4.5 billion after deficit support. We ended up agreeing quite quickly when the reset started, balanced plans, and so far the NHS is on track. But we do have some really material pressures. So resolving the redundancy cost conundrum is a big thing for us. And then also, and I'm sure we'll cover this when we talk about elective progress, industrial action, the impact of industrial action and the cost of industrial action is another key pressure for us.
Okay, let's put the industrial action on one side for a moment. You mentioned the issue of redundancy costs.
Yeah.
It seems pretty obvious that if you're going to cut funding of an organisation by 50%, you're probably going to have to get rid of some staff.
Yeah.
Therefore, there's probably going to be redundancy costs. Isn't it not your personal responsibility? You weren't there at the time. Isn't it, really quite amazing that that wasn't thought of as a key element when the process began?
So it was thought of and discussed right at the beginning, and it's been an issue that we've been working through with Treasury since then. We've had discussions this week as well. Hopefully we're getting closer to resolving the issue. But it is a pretty significant sum of money as well. But you're right, people won't leave without some kind of redundancy compensation. And what we're talking about also, Chair, is at this stage it's voluntary redundancies. In NHS England alone, we have over 3,000 volunteers to take a voluntary redundancy settlement if we could fund it appropriately.
Yeah, but people tend to only volunteer once they get some money to go with, don't they? I mean, just say to Samantha Jones, it is slightly bewildering, I think, to some of us, just as looking from the outside, that a programme could begin like this with not having had the conversations with the Treasury to begin with about who was going to fund this.
I think as Jim has just set out, so discussions were taking place at the time. If we go back to what the Prime Minister and the Secretary of State announced in April, which was the abolition of NHS England and the creation of a new department with a 50% reduction, what we're actually doing at the moment is working through what does a new centre look like, and importantly, who are the people that are going to lead it? We're already out to advert for a number of those senior posts. And really importantly, what's the shape and function of those individual areas within the new department? So as Jim says, ongoing discussions with Treasury in terms of how do we ensure through the right approach that we are able to fund and support people to exit the organisation. I think I'm sure you're going to come back as part of the committee about how we're going to make sure we deliver today as well as focus on the tomorrow from the elective recovery. But what we are doing at the moment is just working through the size and shape of each individual team across the department as part of the discussions.
That's the department at national level, and some people might say, well, perhaps there is an overlap between people running the department and people running the NHS England. But down at the ICB level, how on earth do they begin to plan for next year or even the rest of this year if they don't know when they're going to reduce staff, whether there's going to be the cost of those redundancies is going to be covered by the department, by the Treasury, or they have to include it in their budget calculations? That really is an unsatisfactory situation, isn't it?
It is unsatisfactory, and it was discussed the other day. The thing that we're especially bothered about is how we are treating individual colleagues who, through no fault of their own, they're in this position. There are different ways of approaching this change, though. So the immediate plans were built on a very dramatic, speedy change process that would have incurred quite a lot of redundancy costs up front. If that can't be agreed with Treasury, we have had some discussions with ICBs about doing it over a longer time period in a more managed way, which is possible, but will not get the pace of change and the scale of change that we need in order to deliver our operational imperatives.
Right. It's not. I mean, the issue. You're absolutely right, Sir Jim. That the effect on individuals is important. We should all be concerned about the people who work in the NHS. but also the services to the public, our constituents. Is it possible at some point, because I've still not had this properly explained to me, probably other people have, you could set out for us the current roles and functions that ICBs perform, and what under the brave new world that you are shaping out to achieve, the ICBs will be doing, what functions that they are doing currently won't be done at all, there's a saving there presumably, and what functions will be passed on to some other part of the NHS or local government. And I'll just say local government's concerned that in the end holes will appear and they'll be asked to fill the holes with funding they haven't got.
Yeah. We can get you that. So that's largely covered in the model ICB and model region, but I think we're committed to this on Tuesday as well. We'll get you a note to just clarify how all that works.
And so the saving of 50% will be made without any reduction in service, will it?
It should be, yeah. And all the plans that we've got from ICBs give us the assurance that they can deliver that change without a direct implication for service provision.
And I've just one more question, because it's something that is important about their interreaction between the NHS and local government. I think it's absolutely key. Yeah. Certainly in COVID it proved a great strength where it worked properly. I'll speak from my personal perspective in Sheffield, where relationships with the NHS at local level and the council were brilliant and really helped deliver better services. Now we look as though the ICB's reaction is to pull things to the centre of the ICB, and the place arrangements, particularly local place with the Director of Public Health, Director of Social Care, and the arrangements in local neighbourhoods is going to be pulled into the centre and undermined. That's not satisfactory, is it?
No, so we've been clear that strong place arrangements are essential to an effective functioning of an ICB and those relationships with the local authority sector. This will be complicated in the new world, because every ICB will cover more than one local authority, so they have bigger footprints. Yeah. I would argue that makes the place arrangements even more important. How that's done though varies place to place, and we will just make sure through our oversight of ICBs to make sure that there's strong arrangements and they're functional arrangements, but there will be a local nuance there.
So if MPs amongst others have got concerns that isn't happening at local level, we come to you, do we?
Absolutely.
Right, okay. I'll get your phone number. We'll be on the answer.
If I may, yes, just to build on what Sir Jim said, so the neighbourhood health approach that we are taking is fundamentally about keeping it as local as possible to individuals, involving local councils, making sure we've got local authorities, we've got voluntary sector, and indeed the Secretary of State announced the 42 earlier on this week. But the reason I say that is because they are a practical example of what Jim was describing about it being as local as possible to individuals.
Yeah. Just when the ICB says though, all right, we've got 4 councils, we can't afford to replicate what we do in 4 council areas separately, so that element goes, and it's all said. And quite frankly, the combined authorities, mayoral combined authorities, are not the place where the relationships on health really get delivered. It's with the local councils, the district councils.
Yeah. If I may just add, this is partly why in the 10-year plan we were very clear that the building blocks for ICB future strategic plans had to be those local neighbourhood plans, and we sort of would hardwire that obligation to have regard to those neighbourhood plans into how ICBs were expected to work.
Okay, reassuring. We were going to raise some issues about the surcharges for people coming from abroad to access NHS care. I think we'll probably write to you about those and get responses. That probably will help us move forward with the agenda today. We're just coming back to the issue of reducing waiting lists, and I want to hand over to Lloyd Hatton to begin those questions, please.
Brilliant, thank you, Chair. Where I'd like to start is with community diagnostic centres, which I think in some ways have been a success story in the way that they've delivered tests and scans for patients, particularly closer to home rather than further up the road at an acute hospital. So could you just sort of set out, Sir Jim, where do you feel there has been a success in building up the capacity of community diagnostic centres, and the difference that has made to ensuring that for certainly some patients they do have a test or a scan much more quickly once they've been referred in by their GP?
Yeah. I'll start and then I'll bring Mark and maybe Megan in as well, if that's okay. So first of all, going back to the CDC and surgical hub thing, the big part of that was about the separation of urgent elective care, which is a really key important strategic move for us to try and protect both streams and give dedicated capacity, especially for diagnostics, to avoid the situation where patients might have a scan booked, but an emergency patient comes in and they then get juggled or cancelled or whatever. So we've had a huge programme with a massive investment, an awful lot of extra capacity created through CDCs and surgical hubs. As always, it's a big change, so the activity has grown since they were opened. The range of services is different in pretty much every CDC, but generally an expansion of the range of services as well. And quite a lot of them are significantly more accessible and closer to the high street, with better access for the population. So I think in that regard, they've been a very, very successful development, have contributed towards the reductions in long waits that we've made so far, and are a big part of the next phase as we'll move more to the RTT standard. But we are still struggling with waiting times because of growth and other dynamic factors there as well. So I would say overall, really, really positive start. It's a really significant expansion of capacity, very welcomed by the NHS. Satisfaction rates are very high, so patient satisfaction rates 93% or so, which is really, really fantastic, but still more to do. Mark.
Thank you. So we are delighted that we have 170 CDCs now open, 100 of which are open 7 days a week, 12 hours a day, which is a fantastic achievement by the teams that have set out to open them at a very short space of time. As Jim said, we're continually looking to see the range of tests that should be provided there, and also trying to reform the whole pathway for patients, which means when a patient first sees a GP, the GP can access the tests in the community without the patient having to go and have a consultation in hospital and then come back for another visit to have their tests. So what are we doing is we are putting out a number of what we call straight to test pathways, which means a patient has a certain condition, they will be able to be directly booked in to have the test performed, have the diagnosis confirmed, and then, if it's required, have a hospital consultation, and if not, the treatment can be provided by the GP. So much quicker for patients to access care, much prompter decision-making, and prevents the patients being added to the waiting list unnecessarily.
I mean, particularly in my constituency, I've got a community diagnostic centre in Weymouth Community Hospital, and pretty certain it's one of the ones that is operating 7 days a week, and it is leading to certainly much higher patient satisfaction, and I think GPs like the way it works as well. But moving on, I suppose what my concern is that while the CDCs do seem to be broadly a success story, the overall sort of recovery target for diagnostics has been missed significantly. The chart in the NAA report, which shows that actually it is still hovering at around sort of 20-something%, where actually the recovery target is that it should just be 5% that aren't on track. So I suppose what I'd like to know a bit more about, Sir Jim, is actually, are we just sort of shifting where this diagnostics takes place, rather than actually dealing with the real issue, which is driving down that figure from around 20-something% to 5%?
Again, I'll start and then Mark will come in. Okay, this overall, we were very concerned about this at the beginning. What we didn't want is just shift the location of the diagnostic, and then there's no overall growth or reduction in waiting times. There's a pretty significant growth in actual volume, but coming with that is a growth in demand, and there's also a material factor, which is the growth in non-elective access to diagnostics as well. So the NHS is a very complex, dynamic thing. So we have created this additional capacity, done a huge amount of extra work, but that's quickly backfilled by growth in demand, and we're working all the time to try to make sure that we're controlling the non-elective, the urgent demand as well, to try and protect as much of this as possible. And you're right, overall on the waiting time metrics, we have been a bit stuck, and this is going to have to be something we'll really focus on in the next 12 months or so.
Just on that point quickly, Sir Jim, is your understanding, looking at the chart in the NA report, which looks at where we are in terms of meeting that 5% recovery target, do you see it as flatlining, or do you actually think we will see a significant drop in the short to medium term, or is it actually just going to keep sort of stubbornly remaining around 20-ish%?
All of our plans assume a significant drop over time. It can't flatline, so we have to find ways of unlocking that. But it has been fairly flat over this last year or so.
Can I just add, so by the time we got to the end of March last year, we had over about 82% of patients were seen and had their diagnostics within 6 weeks. Now we know that was we missed the target that was set for last year. As Sir Jim mentioned, we were trying to compensate for a number of different things. So one of them is the growth in diagnostic demand, which was far in excess of the modelling that was done to map out the delivery path for the end of March. So we've been working with the Royal Colleges to look to see how we can influence the range of tests that perhaps are undertaken for some patients that they may not necessarily need as a first part of their diagnostic path. So we're trying to make sure that we're using the diagnostic tests for the specific conditions that patients have all of the time, and also not doing duplicate tests where they're not necessary. And so that is, the digital transformation we're seeing across diagnostics, which is making sure that whether it's a test result, whether it's an image from a diagnostic clinician in one hospital, one part of the country, can see it in another part of the country as well, to prevent the need for repeat tests undertaken that could be overinflating the demand. I don't know if Megan, you want to say anything.
Thank you. So really from a clinical perspective, because these centres are outside of the city and the hospital setup, it's very convenient for patients to attend, and as Jim said, their experience is very high attending these. Typically, a CDC will undertake CT scans, MRI scans, ultrasound, and echocardiograms and endoscopy if they're advanced. I think the clinical engagement in this project has shown that people are starting to develop pathways and one-stop clinics. So for example, in Oxford, there's a breathlessness pathway which the clinicians have developed, which means patients can see a multidisciplinary team and have the test. So they have the test, see a physiotherapist, see a physician, and get their diagnosis on the day. And that has been very helpful and much well received by the patients.
Just building on what you've shared with us today, at the moment, obviously, the vast majority of diagnostic tests don't happen in a CDC. They do happen elsewhere in an acute hospital. If we are to sort of drive down and meet that 5% recovery target, do you see CDCs as playing a much larger role? And actually, particularly, not just over the next year or so, but longer term, will that just be the shift? I mean, certainly what the 10-year plan is talking about is we have that shift from hospital to community setting. Do you see that as being one of the most sort of critical ways that we can meet that 5% recovery target, is to push more and more diagnostic tests into a CDC setting?
It's a key part of the plan, absolutely. And we want to try and protect the hospital sector for patients who really only need to be there. As Sam and others have already said, the big part of the 10-year plan is neighbourhood care and trying to move care more closely, but at the same time change the pathways, digitise as much as we can, introduce new technologies, etc. So there's a really big central part of our plan. In all my time in the NHS, we've really struggled to keep pace with demand for diagnostics. There's things are moving all the time. There are new tests all the time. So we do have a bit of a job to do on all that, but it is absolutely central to everything we're trying to achieve.
Just one very final point, if I may, Chair. On that point, in terms of being able to do that from a cost point of view, because actually delivering it close to the patient often will not be cheaper, and particularly in rural and coastal areas like mine, where actually it is a very sparsely populated community, where actually a lot of people are a long way away from a larger hospital. Public transport is nowhere near as good as we'd like it to be, and in some areas you have maybe 1 in 4 people not owning a car. So there is a real need for it, but can we actually meet that need of having a sort of CDC setting in more and more parts of the country, particularly in those rural and coastal areas where there's the need, but it would be more difficult and likely more expensive to set up and deliver?
Yeah, absolutely. So, I mean, you've rightly highlighted, we've got a bunch of challenges here. We've got the financial challenge, the workforce challenge, productivity, inequalities, making sure we've got equity of access. But in areas, as you've described, we're very, very keen to make sure people have local access, that we're addressing those needs, and that, you know, people make those decisions in a sensitive fashion that take all those factors into account. You know, I don't want to talk about the financial position all the way through this, but a big part of the constraint and diagnostics at the minute is our overall financial position. We could do more tests if we had more money. We're realistic about we've got what we've got, and the service is doing a very good job at managing within the overall resource. But hopefully, as we get through this year, get a bit more stable financially, get on top of waiting times even further, we should be able to open up more capacity as time goes on.
Thank you, Lloyd. Right, just moving on to the surgical hubs. You haven't delivered as many as you planned. Why?
Again, do you want to take that?
Thank you. Surgical hubs are of 3 different types. They could be independent and standalone, they are integrated, or they're part of an existing theatre suite. And initially, the way that the activity was accounted for meant that every site had to have a specific code to make sure that elective procedures which are done in the hub are accounted for separately, particularly if it's already in an existing theatre complex. So consultants and doctors and nurses have focused on undertaking high volume, low complexity procedures in surgical hubs. And this is where clinical engagement has actually shown that undertaking these procedures in a very standard way has meant that the productivity within the surgical hubs is increasing gradually. And theatre utilization for those surgical hubs is in excess of 80%.
Okay. One of the problems is with the figures around surgical hubs that we've got different sets of figures, haven't we? What the NAO found is, depending on which board the figures were being reported to, whether it was the board that looked overall at the transformation programme or that looking at the surgical hubs transformation programme, there were different figures about what hubs had been delivered and what were in progress. So, Mark Cubban, why? How can you run an organisation which has got 2 different sets of figures to different boards?
So we have 122 hubs that are now operational, and we have a few more hubs coming online later this autumn. So we will be on track for the commitment that we set out for this year for the number of hubs that will be open. There was, as the report highlights, some issues in terms of separating out the amount of surgical work that had gone on in hubs, particularly for those that were embedded as part of, just adjacent to, but embedded as part of an organisation in the way that Megan described. Essentially what we've done with all of the hubs that have been expanded or developed as part of the transformation funding that was available, there's a separate code to accurately record all of the activity that's undertaken in those sites.
Come back to that in a second. Okay. You didn't answer the question, I'm afraid.
We've had
Why
some
have you got 2 lots of figures reported to different figures to 2 different boards?
Yeah. So we've had correspondence this week, haven't we, about the numbers and stuff, and most of us weren't around actually formally in the organisation or substantively in the organisation when a lot of this was enacted. I'll commit, Chair, to Sam and I outside of this, just reviewing again the numbers and the different sources of information, because I think we share your frustration and try and clarify the matter once and for all.
Right. An easier question then: how many hubs are still to be started, and how many still to be completed? And have you got the capital to deliver these?
Yeah. So with the investment that we have, we're progressing to open the hubs as part of the schedule we have for this year. So some of them are being expanded, where we've added more theatres to existing hubs, and some we're just waiting to have the full hub opened up. So we have another 14 hubs that will be either expanded or developed and will be coming online to provide the capacity that we need and to get patients with more timely access to the care that they want.
14 over what time period?
So we will confirm the revised schedule with you happily after this meeting, because we have some of the schemes that were planned to open up, particularly for this year. A few of them have run into some delays with some of the estates challenges, whether that's about the construction costs or the sort of construction delays to some of those hubs being open. So the ones we're expecting for 25-26 are all going to be opened as per the commitment, but we will give you the timeline for the remaining hubs after the meeting.
How many will be left at the end of this financial year?
Well, we have 122, and we will have probably about 125 open by the time we get to the end of September.
Right. How many will still to be opened by the end of this financial year?
Yeah. So can I provide the written update on the remaining hubs just when we have confirmation of the timelines for those additional hubs to be operational?
Right. And is the intention still to complete them all?
Absolutely. So everything that we have, with the amount of money that we have invested, we are keeping all of the hubs on track, and we're expecting them to be opened as per the plan we set out. Right.
So we need a new timetable, a new schedule, and absolutely the same numbers that everyone agrees upon.
Yes.
Okay. And that's going to be provided to the
Yes.
Right. Just going back to the issue of identifying with particular codes, the work being done in these hubs to make sure it is additional. One of the problems is that they have additional activity, and that's shown, but a lot of that activity hasn't actually reduced waiting lists. That's not what the money was spent for, was it? It was to reduce waiting lists, but it hasn't actually delivered. It seems that other activities being done in these hubs additionally instead.
No, so the first plan was aimed at reducing long waits. So it set out how it would work through from 2-year waits to 18 months, etc., and work through that plan. That has been achieved. You can see in the numbers a really dramatic reduction in long waits over that period. So if you look at 52 weeks, for example, where we haven't managed to hit the target set out in the first plan, they peaked at just over 400,000. We're under 200,000 now. So we've had a big growth of activity, really significant reduction in long waits, and now this new plan pivots more towards the RTT standard. And on that, also, the list has fallen year on year over the last year.
Yeah, I wasn't saying the list hadn't fallen. I was saying that the increase in activity in these hubs haven't mirrored the reduction in waiting times. Some of the activity in the hubs have gone for being used for other purposes, yet the money was allocated to reduce waiting times. So just Samantha Jones, and that's what the department allocated the money for. Isn't it strange you've allocated the money and then it's gone on to be spent in a different way?
I think we are very clear from the coding that Mark and Jim have talked about in terms of being clear about what activity is taking place in which centre. The other thing that I would like to highlight, and I'm sure Mark will come in on, is the activity and the way that we are treating patients. We are constantly looking at how we're doing that through the use of the digital, making it as convenient as possible, looking at when we're bringing people in for their treatment, looking at how they're being treated, the throughput within theatres. So at the same time as opening the additional capacity, there is also work, and we've got examples from across the country, where we are changing the way and becoming more efficient in the way that we're treating patients.
Yes, but of the hubs may be opening, but of the planned additional capacity that the hubs were meant to deliver, they're only delivering half of it. Why?
I come in?
Yeah.
So the hubs, when the hubs opened up, we did identify a problem where some of the work that had been displaced from very busy sites, and this is particularly for hubs that have been adjacent to hospitals. We have seen a significant change since we've been able to capture the data more accurately, where we're seeing much greater levels of productivity through the lists in surgical hubs, much greater productivity in the use of the beds within the hubs, and we're seeing much greater patient satisfaction as a result. So all in all, the surgical hubs are contributing to the lower waiting list size, the reduction in long patients waiting long.
But only half the amount that was planned in terms of the effect on waiting lists. I mean, because they're being used for other things, aren't they? I mean, you're right. These hubs, they tend to be new, the equipment's nice and shiny, the waiting areas are nice, they're easy for patients to access and go through in a short period of time. So surgeons use them, don't they? Put other of their operations through there rather than reducing the elective waiting times. How do you stop that?
With the data that we have much greater scrutiny of the use of the surgical hubs. So we have review that goes on at organisational level. We have a review that goes on across each region with the GIRF, the Getting It Right First Time team, where we have peer-to-peer challenge to make sure that all of the assets are being used optimally and trying to get as many patients through the hubs as possible.
I think Matt Stahl wants to come in and try and...
If I may, Chair, just to add two things. I think it's critically important that the decisions about how capacity is used about the NHS are clinical decisions made locally, and the most appropriate use of the new facilities will, at the end of the day, be determined, but as I say, by clinical teams locally. I think that's very important. It's also worth saying, of course, that we have had in place across all of the programme robust financial arrangements to make sure that we pay for activity that's undertaken across the NHS, and not for, we don't have block payments anymore. We have payment by results, which we reintroduced as part of this programme, and that's ensured that we've maximised the amount of activity we're able to deliver, but also protected taxpayers, so we're only paying for activity that's actually delivered.
Yes, I mean, I take the point that clinical decisions are absolutely important. Of course they are, and clinicians will decide on priorities and what patients need. But equally, Parliament decides on spending money for particular purposes, and if that money is then used for a different purpose, we have to ask questions about it.
Yes, so just to clarify, I think if you're implying, Chair, that we've opened surgical hubs for elective patients, but it's being used for a completely different range of patients, that's really not happening. They are largely dedicated elective capacity. Over the period of the report, activity was materially impacted by industrial action, and the overall financial position largely related to industrial action. So volume could have been higher through that period, and wasn't, because of that overall just trying to manage within the overall resource limit. But we'll go back and double check, but in my experience and from the data I've seen, elective surgical hubs are being used for elective care, not for urgent care or other services.
Well, it's not quite what the NA report says, and it's been signed off, hasn't it?
Yeah, we will absolutely double check in terms of the point that you're making and come back.
I think it's quite important.
Yeah.
Okay. Just one final question, I'll come on to the issue of outpatients. Just in terms of, these are NHS facilities, but we know now in the current world, many private provided facilities are used by the NHS for patients who do not pay for those services because they are additional capacity. How is that capacity modelled into this? And I'll just raise two questions, from personal perspective, if I might. Got a company called Optica, provides cataract surgery in my constituency. It's got waiting times down to 2 weeks. People think it's a brilliant service. Talk to friends who've been there, counsellors who've been there. Wonderful. They've just been told, reduce your activity, you're too successful. You get people through too quickly. I went to the Cannon Centre the other day, where they living care services provide diagnostic services, modern equipment. Cannon provide it, state of the art. Professional footballers go there. It's that good. It's top quality. Sat there unused. The NHS hardly uses it. Isn't that something that needs factoring in when you're looking at these programmes in future?
It is factored in, and we are very dependent and value our relationship with independent sector providers. Have been a really important partner in delivering what we've delivered so far, and will be in the future. I think what you're describing, and especially the ophthalmology thing, is a very good example where huge expansion of independent sector provision in this area over the last few years, which has materially contributed towards a reduction in waiting times, as well as NHS delivered care. But we did get to the point, and come back to it again, money's very tight this year. We nearly started this year with a £6 billion problem during the planning round. We had patients being offered treatment within a few days in some places for cataract operations. So when local ICBs and providers are working through the plans, and they've got long waits in orthopaedics or in general surgery or in neurology, other specialties, there has been a correction of that, where there's been decisions made to slightly increase waiting times for ophthalmology to free up the resource to provide access for those other patients who are waiting too long.
Right. sometimes looks as though it's so successful we have to make sure it isn't as successful in future. But I mean, that's probably an unfair comment. I get the point you're making. We've got to move on now to outpatients, which has probably been the least successful part of the transformation programme. I think that's fair to say. Josh Fenton-Glynn to take us through that.
Yeah, so obviously outpatients represent 80% of the elective waiting list. So actually the key to solving elective waiting lists is solving outpatients. Yeah. You had a 25% target of reduction. After 13 months, you'd reduced the use by 0.1%, and then more or less you stopped measuring it in the same way. So when you miss something like that, it's either the target's wrong or what you've done is wrong. Mm-hmm. Which did you get wrong?
It's a really good question, and you're right. Outpatients is the key to how this all works in the future. I think we're all still convinced of that and committed to it. Right at the beginning of this programme in 21, 22, whatever it was, when I started it in a previous role, we identified outpatients as a big thing, huge variation. Some examples where follow rates were really materially different, where clinicians had adopted different practices. Surgical specialties are generally quite advanced now in this, but still a huge, a big volume to go at to allow more new patients to be seen. There were mixed clinical views in the clinical community about that, a lot of concern about what would happen to patients who might need a follow-up but didn't get access to the follow-up. So try the PIFU and be using technology to try and support that. And as I remember it, we got very close to some big changes during that long period of industrial action. We had a really good summit in London at one point with all the colleges committed to help, and then we went into a long period of industrial action, and it just was then spent a long period, it felt like over a year, of basically the people who were involved in this having to spend all of the time cancelling and rebooking. So we've regrouped. We're just about, I'll bring Mark in. It is still central. We're having to regroup and work out how we get better clinical engagement and get a new plan together.
It feels like you're not measuring the target anymore, though. So, yeah, what's the...
we've tried to look at it in different ways over the time about the best way to measure what we're trying to achieve, but also incentivise it financially. So we've got some ideas about how we use different financial mechanisms next year. Mark?
Yeah, thank you, Sir Jim. So we've first and foremost, we recognise, and the report highlights this, that we had, outside of the central elective care programme, we had another team in another part of the organisation that were delivering this transformation programme for outpatients. So we've put them together to make sure that we can drive all against the same aim. So we're looking at how we use digital transformation, clinical engagement, bring them together to look at how we can transform pathways for outpatients, because the model that we have for outpatients is very traditional. We've had it for decades, the same model. So many of us will have had outpatient appointments at some time, been to see a GP. GP will refer us to a hospital. We'll be seen by a hospital consultant. Might come back another time to have a test, might need to have a procedure, and then we'll come back in a traditional way often for what we call a follow-up appointment. We need to change the whole model, and there are a number of examples in different parts of the country where that model has already been transformed. So,
I'm going to come to the kind of shift in the model in a little bit.
Okay.
I want to think a bit about resources, though, because obviously 80% of programmes are outpatient. Should that have been more of a focus of where we put resources into reducing elective recovery times, do you think, Sir Jim?
Yeah, I think it should. I think the programme probably was under-resourced at the time, but I think the material issue throughout has been clinical engagement, and we've struggled throughout to get the clinical community uniformly behind it. So once they've done that, once we achieve that, the thing will get resolved. Yeah.
So it feels like we can make a change when we spend a load of money on a diagnostic centre or a new surgical hub, because there's a new building for people to work in. But actually, when it comes to getting clinicians on board and getting buy-in, it's more tricky.
I think it's more complicated than that, to be fair. And there's a huge, I think really, I mean, I'll bring Megan in a second. The big concern that's prevented us from going really hard at it is the concern about missing clinical risk. So if we do really sweeping changes without really strong clinical engagement, that then means a patient should have been seen in a follow-up setting and wasn't and comes to harm. You know, none of us want that. And it is really variable, specialty to specialty. I accept the challenge that it does look like if we can get big investment, things can work. And we all agree outpatients is the big untapped thing for us to go at that can be dealt with without a lot of resource, but it's very complicated.
I mean, if it's untapped, why did we focus the 1.5 billion bid at the start of the year on surgical hubs rather than more money in
I don't think they're either or. I think at the time we definitely needed to separate urgent elective care. We needed more theatre capacity, and from a diagnostic point of view, you'll have seen stats over the years. We've been massively behind other developed countries in terms of diagnostic capacity. So we'll have to try and deal with all of these things in the round.
So back to the kind of clinician buy-in.
Yeah.
Is the barrier the Royal Colleges? Is it the BMA? Is it some mixture of all of those groups?
Megan?
Thank you, Jim. Thank you. So in my experience as a consultant, as a Chief Medical Officer in an acute trust and CEO, and now National Medical Director, I've learned that actually any reform or change management program just cannot work without clinical engagement, and particularly sustaining the benefit of that is also down to clinical engagement. And we've learned from what's happened previously. And if I may describe the clinical engagement now in the elective reform plan at outpatient level or at theatre level, is at local, regional and national level, and there's a lot of activity going on. So at a local level, clinicians have now have access to their own data sets. They can understand their performance, which wasn't the case before. And actually, as a clinician, when you can see your data and you can have peer comparison, you understand what needs to change. So they undertake quality improvement activity. In terms of regional level, there are clinicians embedded within regional levels, and their role is more as an oversight and peer group. And they enable learning networks and improvement guides to make the changes. And then finally, at national level, the Getting It Right First Time program, which is virtually in every clinical specialty now, allows clinicians to see the variation amongst different organizations at specialty levels, such that they can reduce that unwarranted variation by adopting best practice from other centers. And actually, that is replicated also in national level by Mark in his team having 2 national clinical directors that work to him. And actually, I'm also a member of the elective program board. So that increases the clinical engagement. An example of local activity enabling outpatient program productivity is the integrated GP and cardiology clinic, which has actually shifted work to the community and improved access for patients.
So you're kind of telling me lots of things that you think are going right, which is good, and I look forward to seeing the results. I'm not hearing where the blockage is that we've been, it's 3 years on now and we've not really seen much of the change. You've said industrial action, but beyond that, is it Royal Colleges that are not wanting to change? Is it BMA that are not wanting to change?
Sorry, I was just going to. The Royal Colleges actually are very engaged, and we meet with them regularly. There are webinars and roundtables. The Royal College of Physicians put out a publication on the outpatient, it's called outpatient prescription, which very much says what the next step should be. So there is a lot of engagement. I haven't come across any opposition.
Yeah, but it just doesn't seem to be moving quickly enough.
Can I just... just if I could just come in. So I think we didn't get some of this right in terms of how we were applying all the skills that we have in NHS England, some of the clinical expertise across the colleges and within our own organisation, and the clinical expertise that sits out across the service to make sure that we were as joined up as possible about the scale of opportunity and some of the ideas and some of the examples, and worse, we're getting some of this right, and it needs to be shared and scaled up across the whole service. And that's something that we have set about to correct. So we've had some really positive engagement with the colleges around our 5 key problem specialties, and these are specialties with the highest proportion of weights on the waiting list, to look at the right pathways and how we can transform those pathways so they're delivering prompter care for patients with fewer visits to hospital where they can be avoided. So we were instrumental in working with the Royal College of Physicians and the publication that Megan has set out, and we are essentially just at the final stages of completing a whole new approach for how we want to deliver outpatient provision across the NHS from next year.
So you have learnt lessons and you're now kind of trying
We have.
differently. In the more broader way, sorry, and I hope that you can come in on this, Samantha, because in the more broader way that there's been things that haven't worked there and you've had to change the way that you've approached it, how's that going to work for the 3 shifts? Because actually, if we don't get clinicians on board with the 3 shifts, then they ain't happening. The Secretary of State said it's the most revolutionary change in NHS history. If we need a new building to change things, then that ain't working unless we do it properly. So how are we going to get clinicians involved in the 3 shifts?
I'm going to ask Matthew to pick up our governance and our accountability arrangements at a national level. But if I may, I don't think it's right that the committee believes that we need a new building to incentivise people to change things. But what we should recognise is that it is difficult change involving people, patients, and using the services. So, and I think we underestimated that collectively. So what that means in practice, and as you'll see through the 10-year plan and set out by the Secretary of State, is that putting as much as possible in the hands of the people who use the services, whether it's through the NHS app and the use of digital, so that we actually say to people, if you don't need to come in for outpatients, please don't come in. This is how you can access, etc. So there's the...
I'm going to stop you there for a second, because that's really interesting that you say, you know, people not needing to come in and changing patient behaviour. Obviously, there was a target of 25% of outpatient follow-up appointments being remote. Not only have you missed that target, you've gone down from 22% of people having remote appointments to 19% of people having remote appointments. It's not a great start, is it?
So if can I finish your other question, then I'll hand back to Mark in terms of the detail of the individual outpatients. So you asked about the shift that was set out in the 10-year plan. As part of the creation of the new Department of Health and the work that we talked about at the beginning, Jim and I have agreed single responsible officers for every single area across the 10-year plan. What that means in practice is that we are working both across the Department of Health and NHS England, and importantly, really importantly, with local leaders, with local clinicians and people who actually use our services, which didn't happen before. And there is a governance structure being set out so that we're very clear about who is responsible and how that's working in practice. On top of that, we are testing and using individual areas across the country where things work, and I think the Secretary of State earlier on this week talked about taking the best to the rest of the NHS. That's a very practical example about how we're using examples from up and down the country to change the way that we deliver services. And that's been brought.
Can you point to as a good example?
So we have, for example, bear with me 1 second, we have examples from, I'm just trying to bear with me on my...
Sorry, that was an unfair one to drop.
No, we have a number of examples. I'm just trying to find them in my pack. We have at the Queen Victoria Hospital, in terms of so rather than coming in, having your outpatient appointment and then going to a diagnostics, going straight to test. For example, we have examples where the Manchester, thank you. In fact, Mark, you can talk about Manchester because it's obviously your trust, where we've collectively reduced the time waiting for ECG diagnosis. So what we've done, and it's really important that we break this down to individual specialties and individual services rather than look at it from a national perspective, because that's where the change happens. And also other examples across southwest London about a 12-month hearing health pilot working locally with people. In terms of the actual target itself, Mark?
So there has been a shift. We did see a dramatic change, through the COVID pandemic, where it was sheer necessity, I think, that drove the use of virtual kind of tests and the adoption of the technology. And there has been some move away from that for actual consultations that would have replaced, face-to-face consultations. But there has been a significant change at the front end of the pathway using technology with what we call advice and guidance. And what we are seeing is that more
I'm
patients...
going to need front end of the pathway use of technology translating to English.
Okay, happy to do that. Apologies. So if you were going to see your GP and your GP says, normally GP might say, okay, try and treat the condition themselves, but then may refer you to have a specialist opinion, through a hospital team. They may want to see you, and that would be normally through a referral that's sent, which is a process where a document goes for the referral gets assessed, and you get added to the waiting list and wait to be seen. What we have introduced this thing called advice and guidance. It's a process where a GP would initiate a request, and it might not necessarily need a full referral to hospital, but they may ask a question about a type of medication, type of condition, to ask the hospital specialist for their opinion before a referral is sent. So they may do that, and what that allows a GP to do in front of a patient is to be able to treat the patient themselves with that specialist advice. So the patient doesn't have to sit on a waiting list, the patient gets the treatment as quickly as possible.
So fewer people are going through to those appointments.
Exactly.
Might have been,
yes,
okay.
And we're seeing a really significant shift. So over the past 4 years, we've seen continued growth with the use of advice and guidance. This year alone, we were expecting 1.1 million more requests to come through this advice and guidance route. For this year, we have made an incentive payment, a payment to GPs to support the increased adoption for these requests and referrals to come through this route as well. And the whole transformation we want to see for outpatients across the country will be a further strengthening and broadening of the adoption of an advice and guidance model, so that patients can get much more timely access to treatment without them waiting for long periods of time on waiting lists.
I just briefly add one thing, which is that we've talked a lot, and colleagues have talked a lot about the importance of clinical engagement with the Royal Colleges and sort of the sort of national policy making. But I just wanted to add that the outpatient transformation involved quite a fundamental change to the way acute hospital works at every single level. And you're talking about changing the way people do their jobs, not just the clinicians, but also the admin staff, and it's nurses as well as doctors. It's a really quite fundamental reorganisation, and that's why industrial action was so disruptive to the ability of the programme to make progress, because it's a really thoroughgoing operational change as well as big national clinical change as well.
So I guess from a Health Select Committee perspective, my concern is that obviously Sir Jim has been tasked with managing the change to NHS England. We've been tasked with the 3 shifts, and when the key part of this change has been missed, kind of on a previous strategy, I'm very keen that if we're going to have these shifts and have them work, that we get that right.
Completely agree.
Agree.
Okay. We're going to in a few minutes have a short break, but before we do, we'll just finish off this section. Michael Payne wants to come in with a supplementary.
Thank you, Chair, and thank you, colleagues, for appearing before the committee today. Just a question about deprivation, really, and inequalities, if I may, just following up from my colleague Josh Fenton-Glynn's questions. There's national evidence that residents in more deprived areas wait longer for treatment, and Health Watch, certainly the King's Fund, there are other organisations who have put national evidence out there that I think points very clearly to that point. I just wondered if, maybe for you, Sir Jim, or Mr Cullen, is there reliable published data breaking down waiting times by the indices of multiple deprivation deciles? Because I think MPs would be interested in that, and I think more broadly it's an important point. And I just wondered what is being done specifically to target improvements in the areas with highest deprivation.
Yeah, brilliant question, thank you. So that we have now published today actually data, which is what we call health inequalities data, which covers the points that you've raised, whether that's about age, sex, the deprivation indices, and so on and so forth, so ethnicity. So what the data shows is that there are some differences, and what we ask is each local system, whether that's our ICBs, who are commissioning services for their local population, whether it's organisations that are providing services for their patients, to make sure that they thoroughly go through the data to understand what might be driving the difference. If I could give you an example in my own organisation of the work that we have been doing, we've been looking to see why certain groups of patients, whether that's by ethnicity or age group, may have a higher do not attend rate, so they may not turn up to clinic appointments, to surgery or for some diagnostic tests that have been booked. And we found that actually for some groups of patients having to take children to school, and they've been offered appointment for 9 o'clock in the morning. So with the engagement we've done with our patient forum, we've been trying to look at ways that we can modify the booking principles so that they're booking times that allow working mums and dads to go to work. They will still need to drop children off school, but they'll also have a bit more flexibility in terms of when the outpatient appointment will be provided. So there are things like that that we need to get into, and you can only do that by a thorough review of the data that's now available publicly.
Just, if I may press, Chair, on a wider point, is there also specific data in relation to harm caused or clinical deterioration caused by long waits? Because obviously this committee is concerned with value for money for the taxpayer, and clearly harm or clinical deterioration for somebody from a long wait is potentially a value for money challenge for the taxpayer, but also clearly, and perhaps more importantly, a risk for that individual and for their loved ones who are potentially caring for them. So is there data in relation to long waits and harm and clinical deterioration as well?
Shall I pick up the long wait point, and then I'll hand over to Megan to give a view from a clinical perspective. So as has already been highlighted, we've made massive progress on the long wait position, thankfully, because we've had some patients waiting far longer than any of us would like. And we know organisations that have long waits are working really hard to reduce them as quickly as possible. And this year we want to make further progress to reduce the waiting list even further from a long wait perspective. When a patient's on the waiting list, they do get contacted periodically to ensure that we pick up. Well, first of all, the patient still needs to have either the consultation, the test, or the procedure that they're booked for. And we also try and pick up any change in health condition, so that if there is a significant change, which may indicate that there's been a worsening of the condition, the patient can be brought forward in the list and have their treatment provided as quickly as possible. But Megan, do you want to just talk through the clinical process behind that?
Thank you. So particularly over the post-pandemic period, where there were several people waiting long periods for their surgery, clinicians undertook regular harm reviews. And the number of those harm reviews was initially very high, but that has gradually come down. And where harm was identified, not only was that individual's treatment expedited, but also a thorough analysis was undertaken of that as an incident to achieve learning from that and prevent further harm. So that has been done regularly. There is also an increasing collaboration between primary care and secondary care, so GPs and consultants, for sort of being able to get to the consultant quite quickly without having to wait. And most teams, certainly in my organisation, have set up contact points for GPs where they can come through to say, actually, I've seen this patient in my clinic today who has been waiting long, and I think they need to be seen immediately. So that works very well. Now that the numbers of people waiting over 65 weeks and 78 weeks is reduced considerably, that is done again at a regular 3-monthly interval.
Yes. You're fighting to both of us. Sorry, apologies. I was just going.
The opposite.
I was just going to build on the publication of the data on a monthly basis now from a transparency perspective, but also from a local perspective. And at the point that you're making, the reason there is so much focus in the plan, the 10-year plan around neighbourhood health, is for precisely this reason, which is that it happens locally, it is understood locally, clinical teams understand it locally in terms of the services that are best provided, because it's them that are collectively working together to deliver that care. So it's both the publication of the data from a national perspective, but importantly being used locally through the neighbourhood health service. Sorry.
I would just very briefly highlight 2 national programmes in addition to what colleagues have said that have been seeking to address the issue you raise. The first is the Further Faster 20 programme, which has specifically targeted national support to reduce waiting times in those communities where economic inactivity is a particular problem. and also the targeted lung health check programme, which has specifically targeted investment in expanding diagnostic capacity into those areas of the country where there have been the biggest problems with late diagnosis of lung cancer. And actually that programme has successfully it has made great strides in eliminating the sort of deprivation factor in early diagnosis. Both of those programs are being evaluated, and that will be important evidence to determine where we go next on the agenda that you raise.
I've seen some of the impact of the lung cancer and lung disease work in my own constituency.
Would it be helpful just to give you an example of this Further Faster 20 work and how that's applied? So with this programme which is trying to address this economic inactivity issue for patients who have what's deemed to be a long-term condition. So as an organisation just recently where in their orthopaedic service, they have introduced health coaches for patients that have been off on long-term sick for some time, either with back pain or with joint pain, where they've been getting weight loss advice, but also looking at how we can reintroduce them into the job market again with refinement of skills, access to skills, but also getting their health back on track as well. So as Matthew said, it's too early to roll this out across the whole country. We want to do a thorough evaluation, but there are already starting to be some really interesting opportunities highlighted that we could perhaps scale up across the country.
Findings from this session, something that my colleague, our colleague Anna Dixon would have asked if she was here, but she's been under the tender care of the NHS recently for a hip replacement, which I understand is going well. Just about some very simple things that can be done that aren't always done in the NHS to reduce waiting times. One is the sort of shared care arrangements with GPs. Why aren't more blood tests, things like that, just done at GP surgery rather than people queuing in hospital corridors waiting for them? And in terms of follow-up appointments, why is there often a rigidity about, the computer says you've got to come back in 3 months, you come back in 3 months, with no real flexibility for patients to say what they feel is appropriate?
Yeah, I mean, really good points. And the first point on the blood test example, it's a big part of what we're trying to do in the neighbourhood care thing, shift as much of this into primary care, into community care wherever possible, so people aren't having to wait for the hospital system to do it. On the second point, we do have a lot of technology now in the NHS, patient portals and through the app, where patients can choose. So you get a follow-up reminder, it says, need to see you, whatever, in 2 months' time. You have the ability then to change that or cancel it or have an interaction with the clinical team to make it, hold it until you're ready. Going back to the earlier points, it's just not everywhere systematic in every specialty, but that's a big part of what we'll be trying to do in the next couple of years.
So we should see some reductions in follow-up appointments, should we?
Yes.
We're going to have to at some point, absolutely.
Okay, well, I'm sure we'll be wanting to see monitor those. Lloyd, you've got a quick question before we go.
Very quick. Thank you, Chair. Just to press that point again that the Chair rightly made, with things as routine as a blood test, again, when you are looking at rural and coastal areas where public transport is not great, it is often ridiculous, the journeys that patients are making, particularly in my part of the world, where you have someone might be travelling in excess of an hour each way for a blood test. And we're not talking about day surgery, we're not talking about a long-term admission into hospital, we're talking about a routine blood test. And they will drive past not one, not two, but 3 community hospitals to get there, which seems just absolutely bonkers. And I had this conversation with my ICB and the Trust, but to see that shift for the most routine care is absolutely essential for patients in coastal and rural areas. It cannot come too soon.
I couldn't agree more, and again, it's a key part of the neighbourhood thrust to try and address that. I've obviously worked in Northumberland for many years before I moved to Newcastle, and we introduced years ago a miles less travelled metric to try and bring visibility to how we were moving patients around for things that could be delivered locally. That was really effective for a long time there. But we actually separately on the rural remote issue, just this week colleagues have been having an exchange about trying to bring that back to the fore, where there are specific challenges in rural, usually coastal areas. We've generally had regulatory problems, safety problems, sustainability problems, etc. in those organisations over the years, because it's very difficult. So we're going to just try and re-energise that work so that in a few months' time we've got a bit more of a targeted approach and a bit of a plan for how we can make improvements there.
And certainly, sorry, Chair. Certainly from a broader Department of Health perspective, if the CMO was here, the Chief Medical Officer was here, he would be absolutely supporting what Jim was saying in terms of the focus on rural areas and health inequalities, particularly from a health prevention perspective. Apologies.
No, thank you very much. Right, we're going to have a short break now, and we're going to come back at 1:15 and start again. So, order, we'll suspend We're going to try and finish this by 12:15 at the latest. So if we just think with regard to questions and answers and focus with that regard. And we now come on to NHS England's management of the whole programme. Lloyd Hatton.
Thank you, Chair. In paragraph 2.10 of the NAA report, there is sort of an explanation or something as to why there was that shortfall of 3.6 million diagnostic tests. One of the problems pointed out is ministerial delays. Could you just go into a bit more detail as to what those ministerial delays actually were?
Matt, do you want
to? As the report makes clear, the ministerial approval process was a really important part of the overall review of business cases within the programme. That does take time, but it was a very important part of the process, and it was an important part of ensuring that we were targeting resources on the right programmes in the right bits of the country in order to have maximum impact for taxpayers' money. So, yes, it takes time to do that properly, but it's a very important part of the process and a very important part of our overall architecture for safeguarding taxpayers' investment. So,
you don't think anyone could have moved more quickly or more efficiently, whether that is a minister, the wider Department for Health and Social Care, or indeed NHS England?
I think ministerial review of business cases is a very important part of the process. I think we are always looking for ways of streamlining that process and cutting out the bureaucracy. That's particularly important priority right now as we're bringing together the Department of Health and Social Care and NHS England. That gives us lots of opportunities to make sure that we're moving as quickly as possible. And I think it's, both Jim and Sam have been very clear that that's a priority for us nationally, and part of what we need our colleagues in local systems to see is us moving quickly and processing business cases and approvals as fast as possible. So we're always looking for ways to speed it up.
I think also during that period we had all that industrial action, funding of industrial action, reprioritisation of the resource. So there were long periods where we were going through really big reprioritisation processes to make sure that we could live within the overall financial limits that we had. So when you look back now, it looks like there were unnecessary delays, but quite a lot of it was about that back and forth and with Treasury colleagues and others, just to try and make sure we've got the balance right.
Looking at the mistakes that were made there, how do you think NHS England could have done things differently to ensure that we got closer, or better still, actually met that key target, that 95% recovery target?
So as Jim just set out, some of the delays were caused by the reprioritisation of some of the resources that were being deployed to support the improvement in the provision, so more tests, improvements in performance. So I suppose some of those things were unavoidable because they were related to industrial action, some of that prioritisation process. But the processes we have put in place and the governance arrangements that we now have in place will help reduce any of the interface delays between NHS England and the department. Whether that's about how capital is deployed, monitoring the outcomes that the investment's achieving, and the impact that's having on performance. So we have a much more joined up set of governance arrangements between both the department and NHS England now than we did have in the past years. So that should help speed up processes and make sure we can divert resources more quickly to get the outcomes that we're looking for.
And that's evident in real life now. So the closer working between DHSC and NHS England, the mechanics we've got in place with the ministerial teams, etc., has massively improved and increased the pace of decision making.
Just very practically on that, so we have, rather than previously there were two teams doing things, there were two boards doing things, we have single governance oversight arrangements, and in terms of clearance processes for myself and Jim, and making sure, as Matt says, that everybody across NHS England and the Department of Health is living true to the principle that was set out in April in terms of creating a new centre and making it as fast as possible.
Thank you.
Right, on to the issue which has been mentioned a few times of industrial action. Sarah Hall.
Thank you, Chair. Absolutely. So, Jim, given we've touched upon this quite a few times, the recent industrial action, what can NHS England do to plan for or mitigate the impact of that action?
Yeah, well, I'll bring other colleagues in as well. I think we changed our approach for the last industrial action quite significantly, and that did help us maintain more normal planned activity than in previous times.
Did you change it? What was the
So
change?
we changed our approach to safety mitigations and in conversation with the BMA and how those things were handled upfront in preparation for the incident, but also in real time as we went through the industrial action process and the interactions therefore that happened in that period. We had a stronger, clearer message to the NHS as well about trying to maintain as much as possible, rather than, it's very easy to cancel a lot of activity, curtail a lot of activity, make yourself really safe and comfortable. But a lot of us felt in the previous rounds we then actually had quite a lot of spare capacity and could have done more. But the arrangements we had at the time didn't allow that to happen. So just a really big difference in the focus and the preparedness. I was at a trust 2 weeks ago that managed to maintain 98% of normal activity, which I think is absolutely incredible. We've learned, again, we had a big debrief after the summer industrial action. We're going to make some changes ahead of the next one, and we'll do some of that in conversation and discussion with the BMA as well. All again with the objective of trying to maintain even more activity through the next round. So Mark Begener.
Can I just add first? So we take the 23-24 year, where there were quite a significant number of episodes of industrial action. We managed to maintain 87% of our normal activity through that period. The recent round through at the end of July of industrial action, we managed to maintain 93%. This is an average across the NHS, which is, sadly, it's the case that we've got better at managing the arrangements as Sir Jim has set out. I say sadly because of the eventuality of having industrial action in the first place, because whilst we try and safeguard and we talk in numbers, the amount of work we're able to maintain, we're still disrupting access to patients for every single episode. So it's difficult to describe the enormous clinical effort that goes in to prepare for industrial action, to go through the period of industrial action and then in the period afterwards, where we've got clinicians working in really quite different ways in order to make sure our services are safe and we can keep as many of our services accessible. And the administrative task with this, which is often a group of people in organisations that we don't talk too much about, but they're the ones who do all the booking and scheduling, and we've seen millions of patients throughout the periods of industrial action that have had to be rebooked, rescheduled, and then rebooked again because of the delays that we've seen. But Megan, please.
Thank you. Thank you. So industrial action obviously has a profound impact on patients and on staff, and actually the organisation itself. This particular last round of industrial action, I was personally involved with my clinical team, clinical colleagues, in twice daily meetings over the 5 days with the BMA Resident Doctors Committee, and that was to discuss patient safety. So overall, in between 22 and 2024, some 1.5 million appointments were cancelled. But the focus has always remained on patient safety. And what we did from learning from that particular period and applying it to this July 25 was to make sure that there was a lot of engagement and dialogue between me and my team and the frontline chief medical officers and nurse directors. We met with them before the industrial action, during and after, because they really know how their organizations work. They know how it is safe and what to do to maintain safety on a day-to-day basis. And we allowed them to make those decisions, but escalate to us where they felt they did not have any mitigation. We then took that to the BMA Resident Doctors Committee twice a day to negotiate with them. And there was agreement amongst us that actually patient safety is the absolute focus. And that's how we helped maintain safety.
So between those two different sets of action then, was there a reduction in the number of procedures that were cancelled, or did it maintain around?
Yes, as Sir Jim has said, we managed to maintain 93% on an average of elective activity, which is more than we did the previous industrial action period.
Okay.
We're trying not to use the cancellation metric, because what happened in The 18 months or so that we had the industrial action was people got in the habit of not booking activity in. So rather than booking and then cancelling, people just weren't booking the normal activity levels. So we've shifted our focus to try and maintain a normal level of activity and encourage people therefore not to stand the activity down in the first place. Just going back, just try and bring this to life. So the conversation about outpatient reform, we'd all accept we need to do more and we'll have to do more on outpatients. But the very people Mark referred to who we need to work with clinicians to say we're going to completely change this process. We're not going to book these patients in, we're going to do this remotely and digitally. They were the people who were cancelling and reschedule appointments for months on end. It's basically all they did for months. Cancelled, rescheduled, cancelled, reschedules. So it was just completely unreasonable, we thought, to try and expect them to change the whole system at the same time.
Okay, thank you. Samantha, over to yourself. So with this ongoing industrial action, what impact, do you think that the government will be able to meet its 18-week waiting list target by 2029? Is that still realistic? Or?
No change to that.
No change?
No.
And the confidence is because
it's still too early to understand exactly what's going to happen over the next few months, and we said that we would take stock. We are, Secretary of State's been very clear all the way through, that the training bottlenecks that the doctors are experiencing is unfair. And in fact, NHS England published a 10-point plan recently in terms of how we can make the working conditions better. So, and that is important because whilst the Secretary of State has been very clear about no movement on headline pay, we are doing an awful lot in terms of supporting the doctors and also the other professions around their working conditions. At the moment, there are no change as set out by the Secretary of State.
And just to add to that, Superstats today, so there's statistics published today for elective care over the strike period. We have had a slight deterioration in the RTT performance, not as big as we thought it might have been, and the list did grow just over 30,000. That's fairly normal for this time of year as well. So it didn't have a massive hit in either of the main metrics. Obviously, we've got to maintain this. It's who knows what will happen in 6 months' time if we've got continued industrial action. But I think the NHS colleagues, as Mark and Megan have described, did a fantastic job to maintain the levels of activity that they did, also through a summer period as well, when you had a lot of people off on holiday and stuff.
Okay, thank you.
Okay, thank you. So, in terms of the three programmes, the diagnostic centres, the surgical centres and outpatients, there have been different ways of reporting into the NHS system, and it seems some have been better than others at both picking up problems, identifying them, making changes. So, perhaps the diagnostic programme has been the best of those. So, what lessons have you learned from the way that reporting's happened in the past, and what can be improved for the future?
Yeah. So I was the director of elective recovery, sort of partly Mark's role. Mark's role's expanded on the one I did through that period, and it was very clear. I was leading the programme, but other big important parts of the programme are being managed elsewhere and reported in different ways, just because of the way NHS England was set up. We've learned a lot from that, and we've tried to make it more coordinated, more integrated. Mark has more oversight and control over all aspects than he did before. But also, hopefully, as you've seen, we've done some stuff published today and earlier on this week as well. Massively increased transparency of normal statistics, normal data, etc., to add and augment the decision-making, understanding of where people are, how to drive improvement, etc. So, but this is not finished. We're constantly reviewing all the time. We're having a big conversation just now about the outpatient model, for example, and Mark presented into some of our national groups last week about where we think we need to go next, and we'll be having some clinical engagement on that again soon as well.
Right. So you're having a general review, we've discussed it partly before, of how you deliver the programme in terms of the capacity, and then how you monitor whether the capacity is in place, and then you monitor what the capacity is actually producing in terms of service.
Yeah, I'll bring in a second, Mark. Personal view was when we were developing the pipeline of CDCs and surgical hubs, we probably looked at them more of a supply chain exercise rather than an impact process. So there was a lot of focus on how many, where are the, what's the range, how do we get these things actually delivered, and we probably got too late to what impact were they going to have. But again, Mark and colleagues have really materially adjusted how we do things, so that's much more central to what we're doing now.
So should I just add to that, if I could? So there's a single accountable person now for all three programmes, and we have one programme board that oversees all those entities. So we have some subgroups there that look at transformation delivery and also the allocation of the resource to make sure that we can short-circuit any delays that we think might be running into process-wise, and it also allows us to course-correct if some of the investment that is being put in, if it's not quite having the impact that we need, it can allow us to course-correct that through the one unified set of governance arrangements. So I chair the programme board, which meets on a monthly basis, but it's also, we have colleagues from the Department of Health and Social Care on that board as well, and we've also had, it's an open invitation to colleagues from the Treasury and from other departments to attend should they wish. And I wonder, Matthew, do you want to talk about the additional oversight we're putting in place?
Perhaps we can go on to Sarah Hall now, wants to explore the role of the department in this might be appropriate.
Thank you, Thank you for the introduction. Matthew, what did DHSC do to improve NHS England's management of the programme?
Well, I think the first thing I would say, and it's the sort of, very much what the department is there to do in terms of supporting ministers, is to set out those clear goals for the programme. And I think in both the 2022 plan and in the 2025 plan we have done that. It sets out very clear goals, which everyone both across the NHS as well as patients and the public can see what we're setting out to achieve. The second thing is to make sure that we're really clear about the resources we're allocating to support the programme, and we've already talked about the work we've done to sort of ensure that approvals and so on are as fast as possible, so those resources can have impact at the front line as quickly as possible. And then the final thing in terms of the role of the department is to ensure that we support ministers in their scrutiny of progress over the course of the programme. And I think we have succeeded in doing all three of those things. The report does set out, though, some very important lessons for us in terms of strengthening the governance across the full breadth of the programme. Jim and Mark have set out how we've already acted on that in terms of broadening, ensuring that Mark has oversight of the whole programme, that the programme board is looking at all of them, and that we as from the department are around the table with Mark, so we're all looking at the same data and having the kind of same view of performance, as it were.
Given, just going back to what was and the lack of governance in at least two of the programmes, in terms of monitoring from your end and accountability, that must have been an issue at that time, which you can now hopefully rectify. That.
Well, the first thing I would say,
monitoring the goals that you've set out, that you've set the clear goals, but they have to be monitored to see if people are meeting those, right?
Yeah. So as Mark has set out, we have improved the monitoring and the flow of information so that we all have a common picture of delivery in a timely way across all of those programmes. What I would say is that that very much and again I think the report makes some reference to this. The focus of the department through the early phase of the programme was very much on making sure that money was being spent in the most effective way. So we had the what is just known as the affectionately known as CDOG, the Capital Delivery Oversight Group, which is scrutinising the business cases for all of the programmes that we're sort of looking at today to make sure that, for example, in community diagnostic centres, that the right that each of the investments is complying with the criteria for those capital schemes. So had the right range of tests, were in a location that supported the programme's broader objectives in terms of accessibility for patients and so on.
Move on to the next. Yes.
Sarah, do you want
Just
to
very quickly, Chair, if I might.
Yeah,
Mr. Stile, locally in my constituency, we're facing, or we believe we're facing, the closure, actually, of one of the community hubs. And I'm just concerned about perhaps potentially that where we've got this sort of this lack of oversight is not leading to the sort of dynamic decision making we need to see on the ground when people are choosing how ICBs obviously have difficult decisions to make. I'm talking about the Queen Mary University in Roehampton, which is not in my constituency but serves many of my constituents. And I just wonder if you're seeing perhaps as an impact of this failure to kind of properly track how the spending is leading to results, whether that might be leading to some of decision making on the ground not supporting some of the outcomes you want to see.
Well, I don't think we have had a failure to track the impact of programmes. I think we, and as we've discussed, I think we've had pretty good oversight of that. We have strengthened that, but I think actually I think the report says that there has been a failure to track the impact. At the end of the day, I think we're always striking a balance between targeted investment from national programmes to stimulate delivery of particular outcomes across the system, and the flexibility for local systems to, at the end of the day, decide where investment is best targeted to have maximum impact for their local population. That's an age-old problem in running any public service, but particularly in the NHS. And I think that we're always sort of trying to get that balance right.
If I may build on that, so the purpose of the new centre is to do exactly what Matthew just described, which is to cut out the man marking, the duplication that was taking place between NHS England and the Department of Health, and push as much of the local decision making down locally, while still being very clear about the national outcomes that need to be delivered. So, as Matthew says, it's been a constant thing, but that's what the creation of the new department, and that's what we're focusing on kind of doing now at the moment to clear away some of that duplication.
Thank you, Chair.
Good. Yes, Sarah, Karen.
Yeah, I'd like to carry along with that theme and the tracking of spending on the transformation programmes. So, Jim, why did the elective recovery board, which you chaired, not track spending on the transformation programmes despite being responsible for oversight of the programmes?
It was a decision for the NHS England board and management team at the time that the tracking of the financial aspects were dealt with in another part of the organisation, and that it was very clear it wasn't part of the remit of the elective recovery board.
Right, and the impact of that, having it done elsewhere, that must have been significant.
It was a bit frustrating at times, yeah. And which is partly why we've adjusted it all now, and Mark's got more oversight and control of those things. So right at the beginning, outpatients, for example, was in a different part of the organisation, in the old transformation function. CDCs were in that part of the organisation, and how they were monitored and overseen were in different parts of the governance structure as well at the time. But that's all been consolidated now.
In terms of whether the programmes had capacity, resource delivery, was there a delay in getting that information to yourself so you could respond?
We're working very closely together at the time. There's a lot of interactions, so I wasn't completely blind of it. But other people were making the decisions about prioritisation and overall resource. We were in consultation, we were in discussion about it all, but it was very much a different team, different part of the organisation.
Having that fragmentation must have had an impact.
It didn't help. Yeah, it didn't help.
Okay. Thank you very much. Samantha, was NHS England doing enough to understand the costs and benefits of the programmes?
I think if I may, hand to Matthew in terms of the governance at the time. she says, haven't been here 8 weeks. However, the revised governance processes that are in place are exactly as Jim and Mark have set out, which is that we have brought together both the spending, the profile, the activity, the demand into one place so that we have a collective oversight. But in terms of then?
I think NHS England was doing enough to track the impact of the programmes. As I say, there's a very difficult balance to strike between seeking to minimise the sort of reporting requirements and the amount of the sort of bureaucratic load on people at the front line who you are asking to go very much further and faster on delivering the services that matter most to patients. I think the way I would look at it is there are definitely lessons that have been learned in ensuring that that information is all brought together in a consistent way and that the SRO can have appropriate oversight of all aspects of the programme that influence delivery of the overall goal. I think the fundamental building blocks were in place, but it's about making sure that we're using that information as effectively as possible to drive delivery and respond as rapidly as possible to changes.
Presumably you'll be taking that forward with other programmes that come forward as well. So having that, as you said, that collective oversight makes it easier to be able to respond in real time. So as I said before, in terms of capacity, in terms of financial management, if you've got it in lots of different pockets rather than under one umbrella where the decision makers don't have access to that real-time information, then that seems like an unnecessary blockage.
Yeah, and Jim and I are very clear that the clear lines of accountability means that you're also accountable for delivery across the whole. So in terms of how we are both forming the new department, but also how we're working in practice now, that being very clear on that accountability and giving people the tools to do that, which is giving them the information that they require as well.
Thank you.
Okay, want to move on to the next question?
Am I taking that? I think Lloyd.
I can, but yeah, sure.
Right, okay.
So, I think we'll both pick it up. We'll both pick it up, Chair. But that's all right. We can do it in any old order. So long as we all get out on time. What I was hoping to pick up first of all was, I suppose we're obviously going to see this huge change with the abolition of NHS England and a lot of the duplicated work that it did sort of subsumed into the Department for Health and Social Care. Can you explain how we can make sure with that huge process taking place over the next couple of years that actually, what I imagine we as a committee are keen to see, and particularly as constituency MPs are keen to see, which is that actually we meet those recovery targets at the same time. And there's a huge piece of sort of reform there into the way the NHS is run. How do we make sure that at the same time we actually see that those targets are hit, particularly in those areas, as we've touched upon, where actually we're furthest away from meeting those targets?
Shall I start and then I'll hand over to Jim? I think it's fair to say this is something that Jim and I discuss 95% of the time in terms of how do we make sure we both deliver and create the new department but not lose the delivery as we go through in terms of our teams and in terms of the actual delivery of the performance that is required. So just very practically, and I'm sorry to keep repeating that we are setting out the transformation over the next couple of years. We will have a single executive team between ourselves, Department of Health and Social Care and NHS England, and indeed subject to Commissioner approval, we'll be moving to a single interim executive team so that we don't have this duplication that we have, and we'll be doing that very quickly. At the same time, those individuals will be doing two things. They will be responsible and accountable for the delivery and oversight of some of the key targets that we're, for example, discussing today, and forming the new department. So in terms of the teams that they need, the data that they need, in terms of your colleagues' challenge to us rightly about how we pull things into the right place. Whilst all of that is happening, and it is a significant transformation, Jim and I have agreed who will lead on particular areas across this transformation. And I say that because if we're not careful, we could be 7-year-olds playing football in terms of both the department and NHS England trying to do things. So just some very practical examples, of course. being NHS facing and making sure the accountability through the regional directors and through the line continues. But in terms of more practical?
Yeah, I mean, right through into the NHS, we're having an active conversation about this. So as an example, we just published the model region. We've been having a discussion with oversight and performance management responsibilities, moving from ICBs into regions. That's translating into a conversation between regional colleagues, national colleagues on key programmes, ICBs and trusts, to make sure there's a transition that's managed. Everybody understands what's moving when. Nobody falls between any stools. We don't drop a ball. And that's a very active, ongoing conversation at every level. So between national colleagues, as Sam has described, between our organisations, right through into the systems. And one of the big changes in this change programme is how the national programmes do interact through into the system and right into individual organisations out there. So can't just look at it at one point in the system, it's got to be right throughout. I mean, obviously we're going to be held to account on results, and the key test in the end as well, we've achieved what we're set out to. I'm very happy for us to continue to give you assurance at fixed points, not just on the results, but also on the management of the transition, and that the required oversight and management arrangements are in place to deliver that.
Mm. And just building on that, if you could give us a bit more detail in terms of, do you think with the sort of the loss of NHS England and with it all being run from the department, actually that there will be that ability to reach out and engage in a clinical setting with those areas that perhaps are most struggling to actually meet their performance targets, particularly in terms of meeting that 95% target that we've been discussing today? Yeah. Do you think with that big change in the way the NHS speaks, engages and consults, that it will be able to go into those areas where actually performance is worst?
Yeah, absolutely. So again, that's live now. The reason I was slightly late in the break was taking a call from a colleague where Mark has identified a handful of organisations where there'll be some central interaction with them. Next week, Secretary of State will be involved himself personally, where we're significantly away from plan, understanding what's going on, making sure that we're providing the required oversight, support, intervention where necessary. And Mark has a very active Chief Exec engagement group. Megan has engagement mechanisms with colleagues in the service as well. So they'll maintain themselves and develop and adopt through this process as we're changing the more formal governance. We're all really committed to make sure that this change works. It simplifies, it speeds up, it brings clarity, and it's agile enough as things change. It's been really interesting actually preparing for this process, because the report goes back quite a long time. It's quite hard to remember what was happening during the first rounds of industrial action and what happened with the money in that year and the reprioritisation and stuff. So for me, a big part of this is how we respond when something does go off track, because things will. Regroup, make sure we haven't missed something between us, but importantly, get back on the bike and get on to delivering it.
I think if I may, the new department isn't something that is going to be delivering this from Whitehall, and the Secretary of State and Prime Minister have been very clear, and that is a fundamental north star through what we're doing, which is to maintain the engagement and that we talked about before, making sure as much as possible happens locally and it doesn't happen from sitting in Westminster. And that is how we're building the new department. So absolutely clinical engagement, stakeholders coming out rather than kind of doing it internally. And then the other thing, the oversight and scrutiny from the Secretary of State, as you would expect.
Thank you.
I think Matt Starr wants to come in as well.
Oh, sorry.
I just wanted to add a point to the remarks that Jim made and Sam made about how we will ensure that focus remains on delivering the things that matter most to patients and your constituents, and that is and it's in the spirit of sort of lessons learned, as we were touching on earlier as well, is that it's going to be critically important that we set out for the remainder of the Parliament clear objectives for the system and clarity about the resources that are available to deliver those on a multi-year basis and effectively what the rules of the game are over a multi-year period. That certainty, which we are now, we've got a multi-year spending review settlement and we're now translating that into allocations and operating instructions to the rest of the system. Giving frontline leaders certainty over that over a multi-year period is going to be a critical way in which we ensure we deliver what we're setting out to do.
And that sort of leads me quite nicely on to where I wanted to go next in terms of questions. I think a theme that's come through today's session and that many members of the committee have picked up is that actually there has been some areas where when there has been a transformation programme with significant additional resource and funding, there has been a really good outcome, or certainly a big improvement in capacity and the number of diagnostic tests completed. There I'm talking about the CDCs. Other areas, it is less clear whether, when there has been that additional capacity and additional funding and resource, whether it has actually led to a big expansion in capacity and has contributed to targets being met. So and there I'm looking more at the surgical hubs. So what would be helpful for me to understand is, in the future, how are you going to make sure that actually there is that ability to monitor and to track that when there is more funding, when there is more resource put in, that it does actually produce the outcomes that we expect it to, and it contributes significantly to the key targets being met around diagnostic tests. Because at the moment, I think one of the things I felt reading this NAO report was that sometimes it is clear and sometimes it's far from clear, and I don't want us to be in a sort of repeat of that in a few years' time.
Yeah, I'll answer that. So right at the beginning, when colleagues were doing business cases for CDCs and surgical hubs, there wasn't a requirement to say we will deliver X or Y, or you must deliver X or Y. Give us assurance you'll deliver X or Y in terms of waiting times, or impact on the waiting list. That, for all future investments, that will be a key requirement. So we've absolutely learned from that, and that will be embedded into all of our processes as we make investments over the next few years in line with the spending review. But just going back to the agility, there'll be other things that, there'll be something that we're worried about in 2 years' time that we're not talking about just yet. So we've got to make sure that that process is adaptive and changes according to the circumstances at the time as well.
Can I also it would be remiss of us not to talk about the 10-year plan and the reform associated with the 10-year plan, because what we're describing is doing more activity, absolutely right, in terms of treating patients and delivering the standards that have been set out. But to do that over the next few years, we have to change the way that care is delivered, through whether it's through the analogue to digital or from treatment to prevention, and working very closely, both in terms of the activity that is being delivered now, but also the challenge around outpatients, changing the way that care is delivered, using digital in a different way, making sure that the 10-year plan, which is set out, how that is going to shift and support care to be delivered in the future. And so we're doing two things at the same time, is making sure we deliver from an activity perspective, absolutely, and also changing the way care is provided and delivered.
I just come in there, so just thinking about that, just trying to get a sense, do you think it's patient behaviour that needs to change or physician behaviour that needs to change?
I think it's a collective. So the model of care has been, we were talking about this earlier, the model of care has been for almost hundreds of years in the way that it is now. What we need to do is the work that Mark will talk more about, is more of the transformation, involving the patient, involving the families, involving the clinicians, making sure they've got the data, making sure they understand their own performance, making sure that the setup and it is incentivised from a financial perspective to do the right thing. So it isn't one or the other. And of course society has changed and the way that people access care has changed. It's bringing that together.
So may I just add to that? Is that okay? So we know that different cohorts of patients, age groups of patients want to access care in different ways, and we know that through feedback that we get. some are more used to, because whenever they've had interactions with hospitals, they do it face-to-face with a clinician. And they're actually used to waiting, sadly, which is what we want to change, because we also know that for other age groups, they're not expecting to wait. They're expecting to use technology because they can access health advice in other routes outside the NHS, where it's on the phone, on a video call, and much speedier access to some of the diagnostic tests, which is exactly what we're embedding in the model for the future. So we're working really closely with the Patient Association to ensure, and other stakeholders, to make sure that we get a deep understanding about that transition in terms of how care is accessed for patients, to make sure we're getting it right. And we're really important focus for us that we don't isolate patients who need to access care.
So we've got some physician change, some patient change. It's a 10-year plan. You just said the current model is lasted about 200 years. We also have a document here which shows that we've not been terribly effective at changing physician behaviour. What gives you confidence that it's deliverable?
I come in, and then Megan is obviously an obvious person who'll come in, being a clinician herself. So we recognise that this change in outpatient, the way that we access specialist care, needs to change. It's probably unsustainable to continue with the model that we have for the future, because year on year it's growing and growing and growing, and we know there's technology that will enable services to be accessed better ways.
You're telling me you recognise we need to change,
Yes.
which is what you just told me in your last
Okay.
answer. My question is, we've tried change here, it's not really worked. What makes you confident that it will change?
Okay, so we're working really closely with the Royal Colleges. We're working really closely with a group of clinicians, both inside NHSE, who the clinicians in NHSE all work in the service as well, and we're working with groups of clinicians who only work in the service to make sure we can get as much consensus around the model that's going to be fit for the future. It's still not going to be easy, because most clinicians have progressed through their career working in a model where they're seeing a patient face-to-face for every single interaction, and that is something that we're looking to change in the future. So we want to set more of this out in a few months' time.
So is the essential problem that the senior clinicians who you need to get on board, who make a lot of the decisions, are in fact senior?
Megan is probably the best placed person to respond to that one.
Having been involved in a lot of quality improvement activity across the NHS trusts, it is clear that clinicians at every level need to buy into the process change. And actually what I've experienced is when they come up with an idea, it's our role to facilitate that, to say, yes, how can we unblock any obstacles for you that you can make this happen and run. And those smaller scale pilots of change, which they take pride in because their patients are doing better because of that change, it's easier to then spread that as an effect. I'll give you an example in job planning, which is really close to every consultant's heart. It's a requirement that all of them have a job plan. And a job plan, typical job plan, is 10 programmed activities, each programmed activity being worth 4 hours of work. And the direct clinical care that they do, which involves seeing patients, treating patients, or patient-related admin, that has traditionally been very difficult to adopt, to say to everybody, you need a job plan that's signed off. But now we've shown almost doubling over the last 8 months because of the work we've done with them. For them to say to us, look, the demand on our service is X and the capacity is Y. We want to reshape our job plan. And actually saying, yes, let's look at that. I think we understand that, but this core activity needs to be provided. And that's had a doubling effect on that. So absolutely right, clinicians have to be engaged, and there's a way of making them appreciate what their patients need.
I mean, it sounds to me like you want to convince them it was their idea.
They have very good ideas, actually.
If I may, the 10-year plan had one of the largest engagement exercises that including clinicians and including users of the services. And so Lord Darcy's independent investigation and identified where the challenges were. The 10-year plan and the way the 10-year plan was created did involve many of those people that we are actually describing in terms of creating the new future. So just to relate it back to that.
Okay, thanks. Follow
Just one final question from me. And I think, again, it just would be really helpful to understand what the thinking is at a time of significant change in the NHS with the 10-year plan, with the abolition of NHS England. If we look at figure 4 in the NAO report, it shows that obviously meeting the 5% target by March 2025 did not happen. When do we project that we will hit that target?
So can I just check? So I think the target you're talking about is the diagnostic standard.
Yes. Diagnostic waiting time performance.
So we haven't in this year set a specific requirement for the NHS to deliver a target for diagnostics. It's a basket of diagnostic tests, but it remains that it is a target that we want every organisation to work towards. Now, because it is such a critical target to support the continued access and improvement in access to electives, and also for waiting times for other types of services as well. So we recognise there's still more to do. Organisations are still working towards improvement at a local level, but as part of our efforts this year through the planning guidance, we wanted to reduce the number of targets that organisations were focused on to get the greatest impact and buy-in from organisations, clinicians, to simplify the ask to drive up the improvements that we needed to make this year.
And we're actually doing the work now to determine what will go on in next year's planning expectations and for the following 2 years as well.
I appreciate that work is happening now. So am I right in saying, I just think it'd be useful for the committee to know, having not met the March 2025 sort of target, or time by which we wanted to reach the target, is there not a fixed projection for when we think the NHS is likely to meet the target of 5%?
So as Sir Jim said, we are currently looking at the requirements we will place on organisations for next year to deliver improvements across a range of different standards, and we're expecting diagnostics to be featured as part of that review.
So you think next year there would be a fresh date or month or whatever you want to say published for when we meet this 5% target, but right now there isn't, but there will be published one next year?
That's definitely one of the targets that we will be considering.
Okay, just a couple final points. Reference was made, Samantha Jones, to the fact this can't be delivered from the top. It has to be within the organisation. There's got to be a real culture change, hasn't there, to deliver that? Now, I talk to GPs who just get very frustrated. They say, we know what to do, we've been doing it for years, we're fed up being told precisely how to do it. Give us some flexibility, some freedom. Tell us what the targets are, but we'll get on and deliver them. At the same time, you have others in the NHS who literally don't want to move till they get a directive. So how are you going to change that? Who's going to be responsible for that? Is that a prime focus?
Sorry, normally agreeing. So first of all, everything that we do is about ensuring that clinical engagement leads this, and we are working to deliver then hand over the power to the patients in the way that was described. So that overrides everything that we're doing. There are always people on a change curve, as you will know, those people who want to be further ahead, and indeed the Secretary of State, for example, announced the 42 that I mentioned earlier. Those are the people who want to go ahead and make things happen. There are others who perhaps need a bit more support in the way that I'm sure Meghana and Mark will come with in terms of the data. What does this look like? How do we do this peer transformation? And there are others who will need some different type of support, in inverted commas, that the oversight framework NHS England have set out. But importantly, through all of that is making sure it is as local as possible. And those people who want the freedoms will get those freedoms in terms of the delivery.
I mean, what probably clinicians might say to me, GPs in particular, we just don't want one bureaucrat at national level replaced by another bureaucrat at local level telling us what to do.
Yeah, I was just going to add to what Sam said, though, Chair, that what we've been trying to do this financial year is create a more rules-based system where we are less specific about specific instructions nationally, create the environment in which people can do what they need to do, frameworks, guides, payment mechanisms, etc. It is mixed, as you've described, so we can get criticised for being too loose, but also not precise enough and haven't given the instructions. I think that's just about being in a very complex transition. But we believe that slimmer, thinner, more agile centre more rules-based system, clearer mechanisms to support and intervene where necessary, the service will get a hold of this and deliver, as it has done fantastically well over recent years.
Okay, just finally, we've heard from the committee in the past about the digital platforms and the legacy systems that exist throughout public service. We've also heard about countries like Denmark, which have really reprogrammed their digital base in the last few years.
Yeah.
Yeah, we've still got a system here where there's no digital plan for the NHS, really, is there? I mean, we have systems, when we talk about the link between GPs and hospital trusts, consultants, but they're working on completely different IT systems. They can't talk to each other. The patient records held in different places. Now, how do we move a system forward with such fundamental contradictions?
Yeah, so there is a lot in our plans, in the 10-year plan and in other plans, especially about that integration and record sharing across the system. It is a key weakness of our system. There's been a lot of foundations laid in recent years with new electronic patient records and stuff out in the service, but technology's moving really quickly. My personal view is a lot of the value over time will be driven more by patient-led, consumer-led technology that allows people to manage their own care, self-manage, interact with clinical teams. And there's a lot of technology now being made available into the NHS. We're going to have to spend a bit of time in the autumn to work out the role of the centre in that. How do we make sure there's a healthy market? How do we have payment mechanisms that enable organisations to adopt this technology and move away from big capital central bidding processes into more agile, more rapid processes? A lot of this technology is much more agile now. It's cheaper, it's more easy to procure, but our processes currently don't support that. But we are dependent on it. It's and the rest of society is changing this way. One final thing, I always get a bit irritated when people compare us with other systems, because they usually compare a massive, full, comprehensive system, which is our NHS, compared to usually quite small, discrete systems that are much more able. So a lot of the countries we get compared to often are the size of an ICB or the size of Mark's organisation, for example. There's no other system that is as joined up and as comprehensive as ours. So when we're trying to make technological change and make it consistent across that kind of footprint, it is very complicated.
Can I just build on? So the 10-year plan set out the requirement for the single patient record, and then of course the NHS app being the front door to the NHS, and making sure that as we would do in any other part of our life, making it as easy as possible for the join up to reduce the fragmentation for patients and carers who are using the services.
I get that, but I would hope we wouldn't take the view that we can't learn anything from other countries as well.
Well, we're not saying that.
No. And it still is a challenge. You have patient records, but the patient records held by a GP are different to the patient records held by a consultant. It's not a great place to start, is it?
It should be full integration, or at least visibility for everybody of what the whole patient record is. Importantly, the patient needs to see it, I think.
Okay. Right. Thank you all very much for coming today and answering our questions across a range of subjects, probably additional ones to the ones we set off going to look at. So thank you very much for coming. An uncorrected transcript of this hearing will be published on the committee's website in the coming days for anyone who wants to read it. We're now going to consider the evidence provided, and eventually we will produce a report which you'll receive in due course. Thank you once again.